Hey, thank you very, very much, Dr. Ho. I'm really grateful to Dr. Liang for inviting me to give this lecture. And it was actually his idea how I should put together so much of my research in the last 10 years that seems to come together into a common story about the intrinsic fertility of the human oocyte related to age, and also how the primordial follicle works and how ovarian recruitment and ovarian reserve works. Now, can you hear me all well? Is the microphone working? There will be a few videos coming up also. But there is a paper I published in JARG last year which kind of summarizes what for me, is most interesting about our clinical studies, which is the scientific implications. And I think we've really uncovered a lot, which I'll discuss with you, about ovarian reserve, preserving ovarian reserve, delaying age of menopause, what really controls, why it is that after 20 years of research, for example, Dr. Gilchrist Kill has a hard time trying to culture primordial follicles, because we all do, and what does it really mean? And actually, the long-term duration of function of ovarian tissue transplants, which has been a peculiar observation for us, despite just a little tiny piece with very low antral follicle count and extraordinarily low AMH, these pieces of tissue last for a very long time, and the results are frankly extraordinarily robust. You don't realize that by reading little case reports all over the world, but we really have a consistent in one single center series of patients with ovary transplants, fresh and frozen, and we really can compute a good denominator for the success. So first place, what is the mechanism of primordial follicle recruitment? Because I think that's one of the first most interesting scientific implications of our clinical work. This, you can see, is the very first ovary transplant, and if you look carefully, you'll see it's sutured to the denuded medulla with microsutures of nylon. You can barely see, and there are no adhesions. There will be no adhesions after this, and you can see that we've also sutured down with microsutures in that little valley this graft, like a skin graft, so that there won't be microhematoma formation, preventing revascularization. So I think we found the technique is very important for getting good results. But what we're talking about here this is a slide from Katsuhiko, which shows there's this one little spot in the epiblast that's specified eventually to migrate to the dorsal ridge and eventually to become germ cells. And this is the origin of PGCs. And then they migrate up towards the dorsal ridge, and it's a complicated process I won't go into now, but the point is when they finally enter in this case, the ovary, then they're turned into female-specific gametes. So first, let's talk about our results when we analyzed a group of 14,000 natural cycles with single embryo transfer and no leftover frozen embryos. This is a very, very important clinical study because it was the only way that we could really determine, not with ovarian hyperstimulation or multiple embryos or multiple frozen embryos, single embryo transfer, natural cycle, no stimulation, what is the intrinsic fertility per egg, not per embryo, per egg of the human oocyte over time. And and then the next study that we'll talk about that helps to explain our point is this huge study in Japan of 24,000 women that were studied for age of menopause and what are the factors that determine age of menopause. Now, if we put our results with ovarian transplantation together with some of these data, begin to understand better what controls primordial follicle recruitment. First place, this curve shows the age of menopause in Japanese women, with is kind of an average of age 51, which is similar in any population you look at any place in the world. Now, if you superimpose on this graph Japanese women who have had a unilateral oophorectomy, you hardly see any difference. So losing half of your ovarian reserves seems to have no impact on when you lose all of your ovarian reserve, and there is some mechanism that slows the rate of primordial follicle recruitment so that you don't have an earlier menopause. And then we combine that with the intrinsic fertility of human oocytes we published earlier this year from this large retrospective study I just mentioned. And we look at an extremely robust graph that Helen Skoletsky put together with data from these 14,000 cycles. And you can see that there is about a 10% loss of fertility per egg, that is live baby rate per egg, up until the age of 35, but then a dramatic loss of 10% per year after age 35, and actually not that much of a loss from age 43 and age 42 on. So the intrinsic fertility per oocyte in natural cycle is greater than reported in hyperstimulated cycles, varying robustly from 26% to 4% with age from less than 35 to 42 years of age. The curve is relatively flat until age 34 and then declines rapidly 10% per year thereafter. Now, the live baby rate per oocyte with no stimulation for patients under 37 turns out to be extraordinarily high, 26%. The index papers, both by Patrizio and Cobo, done separately, showed that for the same group of women with hyperstimulation, the index live baby rate per egg is only 5 to 6%. So without stimulation, where we can see the intrinsic fertility of the human oocyte, it's about 5 times greater with no stimulation than it is with standard hyperstimulation we use in IVF. And we can model this graph in any way we want, and because the numbers are so large, we can even find that there is a very, very slight, statistically significant, I don't think clinically significant, but statistically significant decrease in live baby rate per egg with oocyte with A3 transfer than with blastocyst transfer. But with that slight statistical difference, nonetheless, it's very, very dramatic how this holds up. So from Patrizio's paper with what I think is the index value of the fertility per egg in stimulated cycles, they evaluated a total number of oocytes and the number of embryos transferable, and in patients with remaining frozen embryos, the final live baby rate was estimated. Now, in our case, we didn't estimate it. It was very accurate because we had no extra frozen embryos left over. But Patrizio did the best job he could of trying to estimate what the live baby rate per egg would be by including the frozen embryos. And this is a busy slide, but you can see over in the right-hand corner that for donors it was 7.7% babies per egg, and for women under 35 it was 5.5 babies per egg for women under 35. So that compares dramatically to the 26% per egg that we found with no stimulation. So the overall oocyte to live baby rate was 4.6% in Patrizio's group, and for when analyzed by groups, the oocyte to baby rate was best in donor cycles and declined to 1% for patients over 40, and there was no increase in oocyte to live baby rate success rate if greater than 15 eggs were achieved. So during ART cycles, only approximately 5% of fresh oocytes produce a baby. Now, Cobo did this with frozen eggs, but nonetheless, her results were remarkably similar. And she showed that the oocyte to live baby rate was 6.5%, and it increased progressively according to the number of oocytes consumed. So that if you had as many as 40 oocytes, you could give the woman a 97% chance of probably being able to have a baby. But it was only 6.5% per individual oocyte. So something about having a stimulated cycle either brings out the worst eggs plus the good eggs, or it even might have a negative effect on eggs. But certainly this is not just a statistically significant difference. There is a 5-fold difference in the fertility of the oocyte that we see in our stimulated IVF cycles and the true intrinsic fertility of the oocyte. So that's why we found with ovary tissue transplants that we'd be happier if the patient got pregnant naturally than if she got pregnant with IVF, presuming no cause for IVF was necessary. So our transplants were done in such a way that the fallopian tube was in a position to pick up the egg, and there were no adhesions that would prevent that. So first we'll talk about fresh live ovarian transplantation. And our first case was in 2004 and published in the New England Journal of Medicine in identical twins, one of whom had premature ovarian failure in her teen years, and the other of whom was completely fertile and already had 2 babies. It's a very, very unusual series. And we actually did, we found 10 of these cases that were completely discordant, even though they were monozygotic twins. Before we discuss it a little further, those cases and then the frozen cases, just to remind you that all the primordial follicles are located in the cortex. And when you see a follicle developing, it's not as though it's developing and exploding toward the outside of the oocyte as it appears. It's actually developing towards the soft inner tissue, which is not significant. It's really a real any kind of soft tissue will do. But primordial follicle development and secondary follicle development and even Graafian follicle development always occurs in a tissue rigidity related gradient. And that's really the key to what is clearly a non-hormonal regulation of the first 4 months of that oocyte's life after it leaves the primordial follicle and gets ready for ovulation. So this again is another example. You can see all the significant oocytes, 200,000 of them, are located in primordial follicles on the outside, in the outer cortex, and they only develop toward the inside to primary and secondary follicles and Graafian follicles. And so if you just take the outer millimeter of surface of an ovary, the cortex, nothing else is important. And that's where all the primordial follicles are located, and it allows you to treat it just like you treat a skin graft, both for transplantation and for freezing. So this is what that same piece of tissue looks like to the surgeon when he just shaves off the outer millimeter, or actually the outer cortex of the ovary. And this was a diagram of a picture of our very first ovary transplant, in which we took a piece of tissue from the donor and transplanted it onto the denuded medulla of the recipient, who had no follicles whatsoever and had been menopausal already for 10 years and was now 25. And you can see from all of them that we took great pains to do microsurgical suturing, and this wasn't reported in other programs, and to allow there to be a natural relationship between the loose fallopian tube that could pick up the egg on the surface of wherever it was ovulated. Now, this is that first patient, and it was a stellar patient. She never actually menstruated because when we expected her to menstruate by about 4 or 5 months post-op, she actually had a positive pregnancy test. And that was with no IVF and no gonadotropin, no stimulation. I'm sorry, Ferring invited me to give this talk, but we didn't use any Ferring products for this. Sorry about that. She just got pregnant on her own with intercourse. And then we developed a series, actually, of 10 of these identical twins, called from all over the world, extraordinarily unusual series, which provides us with a great scientific opportunity I'll tell you about in the end, relating to developing human stem cells from egg cells into from skin cells and developing it into human eggs, taking the work of Hayashi and bringing it up to the human level. It is perfectly suited for this series. So then that was published. We had a series, and the series looked very good. And if you add up all of their results on one graph, you can see the FSH always came down to normal by 4 or 5 months post-op, and that's when they started to menstruate and ovulated and get pregnant. So I'll give you the results in a minute, but first let's talk a little bit about cryopreserved ovary transplantation. This may be what more people are interested in from a practical point of view, because either women have cancer and about to lose their fertility from cancer treatment, or maybe a young woman just doesn't want to get pregnant for the next 10 years and wants to preserve her fertility. Or maybe she never wants to go into menopause and she doesn't want to have to ever take HRT. All of those issues can be solved just by thinking ahead and having a unilateral oophorectomy. And as I showed you, unilateral oophorectomy does not reduce fertility and does not hasten the time when you have menopause. So by taking out an ovary and freezing it and transplanting a piece of tissue at a time, you can have natural hormone secretion until you're 100. So our overall results, just so you want to know that it really is successful and very robust, I can go into more details is ahead of time. From the fresh ovary transplants, 7 of the 9 got pregnant with 11 healthy babies, and of the frozen transplant for cancer patients, 10 out of 13 became pregnant with 13 healthy babies. One of those patients actually has 4 babies from her transplant, a Hodgkin's patient. So in general, the pregnancy rate seems to be pretty consistently 77 to 78%, and it doesn't matter whether it was vitrification or slow freeze. Lately, we're only using vitrification because it's easier, but we have great results with slow freeze also. 11 babies from 9 slow freeze cases. So we have a total of 24 healthy babies from just one center. And there's over 100 healthy babies from frozen ovary tissue all over the world. So I don't know why it should still be considered experimental. But I'm more interested in this talk and going into what are the scientific implications of this, because clinically this is clearly robust and it's something that should be offered to every cancer patient.
Dr. Sherman, SILBER,
listen to this.
Infertility Center of St. Louis. And I'm here with the most amazing fertility story ever. This is Amy Tucker. I've known her since she was a little 19-year-old girl who was facing death with Hodgkin's disease, a terribly difficult case. And she's got 2 children from her frozen ovary that we froze before she underwent her chemo and bone marrow transplant that sterilized her, and she's now pregnant with twins. She's going to wind up having 4 children from this ovary we froze before she had this life-threatening cancer and was treated for it. Here's Amy.
Yeah, hi. So yeah, it's been quite the experience that we've had. I wouldn't have guessed when I was 19 years old. I wasn't really thinking about family, and I remember being approached about freezing the ovarian tissue by a nurse, and I was in the right place at the right time.
And she's now 38 years old with 4 babies, and she was told she was going to die when she was 19, and we froze the ovary, promising her nothing whatsoever. It was just part of an experimental.
Giving new hope to cancer patients like Melissa Durant.
The fact that I couldn't have children really scared and frightened me.
2 years ago, at the age of 21, Melissa was diagnosed with Hodgkin's lymphoma. She was told her treatment would include very high doses of chemotherapy.
I thought, I'm young, I can do it. The odds are looking really great for me. Hodgkin's lymphoma, very curable. And then I really started looking into my papers and my books that you get, and I came across fertility, and I burst into tears.
Well, Melissa, this is a fantastic moment for all of us.
It is.
I mean, when are you going to have the baby?
She had 2 bone marrow transplants, and this is 13 years later.
From yesterday, so 6 more days.
6 more days, and you look really ripe.
I am very ripe, yes.
There's her baby, and she's still functioning with that transplanted little piece of ovary tissue.
Well, I'm here with
and here's
Jennifer,
leukemia.
who's one of our most exciting, interesting patients. Her name was O'Brien then. She was 23 years old. This was 21 years ago when she was told she had leukemia and was really in severe danger of death. And just before her bone marrow transplant, we took out an ovary and froze it. What do we think?
You were very, very optimistic.
Oh, really?
Yeah, you were. You were.
Okay, yeah.
And because I remember walking out of our first meeting just so elated, thinking that I was able to preserve my fertility.
I'm always optimistic, and I was hoping we could figure this out, but it was really a long time ago.
It was.
I didn't want to contradict her, but really I told her this was the first piece of ovary tissue we ever froze. It was in 1997, and so she's got basically a 24-year ovary, and she's now 44 years old, and she just delivered her first baby. And we found that if you freeze the leukemic tissue, the ovary tissue, when they're in remission, it's safe to transplant it back, and we now have 3 such leukemia patients with babies and functioning ovaries. So there's a benefit of ovarian tissue freeze for cancer patients to egg freezing. Less time or even no time to wait for cancer treatment, 1/10 the cost, less troublesome than going through ovarian hyperstimulation, and you get return of hormone function as well as fertility of the eggs. This is kind of a summary of these 13 cases, and if you look to the right, you can see most of these little pieces of tissue are still functioning, and they have a lot more ovarian tissue still in the bank, so that I think they have enough ovary tissue to last them for a lifetime if they live 100 years. And all of these babies you can see recorded here all came from natural conception, nothing from IVF. This is sort of a summary of pregnancy that emphasizes those who had slow freeze and those who had vitrification, and I see no difference in results. Now, vitrification resulted in no egg loss. Slow freeze resulted in a loss of about 60% of the eggs. But if you're starting out with 200,000 eggs, it doesn't matter clinically if you lose half of them. And so the results are good with any crude method you want to use. This is the method we use for quilting the pieces of ovarian tissue after we thawed them. Because again, our emphasis is going to be to avoid adhesions, to do it very delicately, like a plastic surgeon would, so that you have no adhesions and you can rely on natural conception. And I'll tell you in a minute why natural conception is important. In a minute, that'll be very clear. So that's our first frozen graft. And that was to this woman who ran out of tissue. And there, this is a beautiful picture because it shows her holding her baby from a fresh transplant, and she's pregnant with frozen tissue right now and has healthy babies from fresh and frozen transplants. Now, a peculiar thing happens after every one of these transplants. That is, when the FSH comes down to normal by 4 or 5 months, there is a rapid rise just from one little piece of tissue. That's a big rise in AMH from a little tiny piece of tissue. And then that comes down to very low levels, and then it functions for years and years and years with very low levels of AMH. So I think this at once tells us something. It seemed like a mystery that after the transplant, for some reason, we get an over-recruitment of primordial follicles, and then with a very, very depleted graft, just one piece of tissue, but even that piece of tissue has been very depleted, that ovarian graft lasts for a long, long time, so that a 24-year-old piece of tissue is functioning quite well in a long time, for over 4 years now, and a 44-year-old who you saw just delivered, leukemia, who just delivered her first baby. So what we found out is it really does take about 4.5 months for recruited resting follicles to reach the ovulation stage. You saw that already. And these tissues have a very, very long duration of function. And we can emphasize that in the second identical twin case, who were 38 years old when they first came to us. Crystal already had 2 children, and Bonnie had been in premature ovarian failure. And after we did the transplant, 38-year-old ovary, it lasted over 8 years, and there she is with her 3 children from a piece of ovary tissue that was 38 years old, 42 years old, and then 45 years old, and she got pregnant naturally without any stimulation, without any attempt at IVF. And finally, at age 46, it stopped working, and we have more tissue to give her. And when we compared the FSH and the AMH of the donor to the recipient in these cases, what we found is there was really no significant change in the AMH of the donor, but we always found this issue in the recipient of a over-recruitment of primordial follicles, an elevation in AMH by 4 or 5 months, going down to very low levels, and then the graft just lasts for 5 to 10 years despite extremely low AMH. So there's a massive primordial follicle recruitment due to sudden decrease in stromal tissue pressure, which is the mechanism, I think, of oocyte arrest. And I've discussed this in previous papers, but I'd like to show for a second our technique of preservation with vitrification. All we do is we just skim off a thin 1 millimeter thick section of ovarian cortex. You can see it's translucent, and we put it on a metal grid so that it's completely dry. It's absorbed all the cryoprotectant, but we don't want it in cryoprotectant because we want rapid freeze. And we know that the cryoprotectant is completely absorbed by 25 minutes by the fact that it falls down to the bottom of this very, very viscous cryoprotectant. And it's as simple as that. And then we just do instant plunge in liquid nitrogen. And you can see this is the fresh human tissue pre-freeze, and no pathologist can tell any difference between the human tissue post-vitrification. And vitality testing showed that with vitrification, we lose really no oocytes, essentially, compared to controls. And with slow freeze, we lose a little over half of the oocytes, but that makes no clinical difference. So then we take the quilted tissue, and we thaw that, and then we transplant that again under the microscope through a tiny mini lap incision onto the denuded cortex. And sometimes it's tricky to tie the knots, but we are always irrigating with heparinized saline to avoid adhesions. And now you see the critical part of every transplant to make sure that that fallopian tube has plenty of room to reach over and grab the egg whenever it's ovulated. So we don't have to rely on IVF. And the reason we don't have to rely on IVF is you get very few eggs when you stimulate these patients because there is a very, very low ovarian reserve. So here you can see the return of FSH after a frozen graft is really not much significant difference from after a fresh graft. Here is the patient you saw who had a lymphoma at age 19. We froze her ovary tissue in 1997, having no idea it would be safe to transplant it back or that we'd be able to culture primordial follicles. And we still don't think it's going to be very easy to culture primordial follicles to avoid cancer cells. Here's her completed transplant of a little piece of that tissue 12 years earlier. And there again you can see she has absolutely the same rapid rise in AMH at 4 or 5 months, going down to very low levels. The tissue is still functioning, and as you saw, she has 4 babies, and there she is with 2 of her babies, and there you can see with the newest 2 babies. And there you can see with her 4 babies and her husband that came from that one little piece of tissue, and she is an oncology nurse but never dreamed 20 years ago that she'd be able to have children. Here's the first leukemia case. You can see she had leukemia and she was young, and her growth was so stunted she's even shorter than me. And it was 15 years earlier, and she had the tissue sent to us. But the critical thing is her tissue was removed and frozen when she was in remission before 1 of her 2 bone marrow transplants. The same return of AMH and FSH. And here's another leukemia patient that you've already seen. With her husband, she's 41 years old and decided to have her ovarian tissue transplanted back.
I'm here with Jennifer.
And you've already seen this video.
Exciting, interesting patients. Her name was Ovarian then.
Ovary
she was
before she delivered.
Old.
She just delivered a few months ago. And these are a summary of our leukemia cases, and we have actually 4 healthy babies from these 3 women with leukemia. So leukemia is not a reason for you not to freeze ovary tissue. Here is a massive teratoma that was sent to us from someone else who did a bilateral oophorectomy, and we just sliced off the ovarian cortex and froze it, and she'll be able to have children. Here is a 35-year-old dermatologist, and she's beautiful, doesn't want to have kids or get married for the next 5 years or so. She has no cancer, but she says that she absolutely wants to have children in the future, so we just took off one of her ovaries. The average patient might not want to do that because they'd be afraid it was too invasive and too destructive, but she is a very sophisticated doctor and knew what she was doing. Here's a 35-year-old woman in the same way. Now, she had breast cancer, and she said, even if I didn't have breast cancer, I don't want to have children for another 5 years, so maybe I should freeze an ovary, which we did, and we'll have no problem preserving her fertility. Not everyone has cancer. This is a patient with multiple sclerosis, and the most extreme treatment for the worst multiple sclerosis now is a bone marrow transplant, which she had. And we froze her ovarian tissue before her bone marrow transplant. She was absolutely cured of her multiple sclerosis, transplanted the tissue back. She now has her periods back, and she has a baby. So obviously ovary freezing and tissue grafting works, and for ASMRM to rule it as experimental for cancer patients really isn't appropriate. Why do these grafts last so long? Because I'm more interested in the scientific concepts, actually, than the clinical work. First place, they have a very low antral follicle count, they have a very low AMH, and only 1/4 to 1/6 of a single ovary is present, and that piece has been depleted by over-recruitment. And this is the Japanese study I showed you that demonstrates that removing one ovary, even if you're not going to have cancer treatment, does not really result in a loss of fertility or an earlier menopause. So it was Klaus Anderson and Hamish Wallace that first, in their paper, recommended this very dramatic point that recruitment of primordial follicles becomes reduced in parallel to a reduced ovarian reserve. By replacing one single piece of cortex at a time, recruitment rate will constantly be very low. Utilization of follicles may be augmented compared to nature. So it is likely that one ovary or part of an ovary will have the capacity to provide menstrual cycles for a considerable period of time. Now, why is all that working? Why don't we understand the biochemistry and the control of primordial follicle recruitment and indeed meiotic arrest in the fetus? It seems crazy. It's a convoluted system. So I'll remind you that I'm also a urologist as well as an embryologist and a gynecologist and a transplanter. And this is what a normal testis looks like at Tessa. And you can see that that tunica albuginea has been tested by anatomists on tensiometers and is the toughest ligamentous tissue in the body. There is no more dense tissue in the body. And that's so it protects our testicles when we're tromping through the jungle. But also, also in the female, because it's the same structure in the female, it has hijacked a very, very important function. So this is normal ovarian cortex which we're cutting in order to do freezing of ovarian tissue, and it looks no different really than the tunica albuginea of the male. And mind you, the tunica albuginea, before I get to this slide, tunica albuginea of the male is very interesting in that all little male boys with leukemia have massive leukemic infiltrates into their seminiferous tubules, into their testes. Their testes is filled with leukemia, but not their tunica albuginea. Tunica albuginea has no leukemic cells in it, in the worst cases. So there's something about this dense fibrous tissue that is really hostile to metastasis and has allowed this whole process to work. Now, this is a slide from Joe Romero because he likes to do IVF on these patients. So he did stimulate this patient, but he stimulated her in the first 4 to 8 months. Why is that? Because you can get lots of eggs during that period of over-recruitment post-op. But if you wait till after 8 months to do IVF, you'll only get maybe 1 egg at most because it's an extremely low ovarian reserve. So I rely on spontaneous conception. But if you want to do IVF, then you've got to do it in the first 4 to 8 months post-transplant. Now, this is a curve Helen Skoletsky from MIT drew, combining together all of these cases with a dot graph, and it's very, very clear that as you get the AMH to go down, as the FSH goes down, the AMH goes sky high for that little piece of tissue, and then goes down to extremely low levels and continues to function for years and years and years and years. So that provides a unifying theory of adult resting follicle recruitment and fetal oocyte arrest. What can the primordial oogonia do to prevent themselves from continuing through meiosis and disappearing by the time of birth? So this is a drawing by Klaus Anderson, who figured this out a long time ago, but really didn't talk much about it. It's those small follicles that go to the ovarian cortex that persist in the fetus, and the other follicles that didn't reach the cortex and that weren't these tiny follicles, didn't become primordial follicles, these all disappear. So when you hear about all the fetal oocyte loss, they don't have loss of the follicles that became primordial follicles and entered the cortex. So what controls the recruitment of follicles in adults from the resting phase and the gradual release from the fibrous cortex, just like in the fetus? It's the stromal density gradient. And if you look at any piece of ovarian tissue, you're going to freeze. The most dense part is outside. As you go more inside, it becomes less dense and less dense until finally you're not in cortex anymore. So these small pieces of ovarian tissue last a very long time. If we were to add up the duration of a piece, 1/4 of the duration of the ovarian cortex, and multiply by 4, this tissue, which is lasting up to 10 years, would represent much more than expected if left in vivo till menopause. So tissue pressure is the key, and that is the missing ingredient that we've always been confused about. Over-recruitment of primordial follicles followed by depletion. Decreased primordial follicle recruitment with decreasing ovarian reserve. Long duration of transplant function despite very low AMH. late menopause in multips, and think about the horse ovary. The last two I'd like to mention. We know that these multiparous women that keep on having babies over and over again, like in the Orthodox Jewish population in Jerusalem or in the Hutterites, or we know that they have a remarkably later menopause, and there's no reason for them to have a later menopause because their early antral follicle counts in life are really no different when they're young than other populations, but they have a later menopause. So what happens is they constantly have increased intra-abdominal pressure. And that intra-abdominal pressure helps to control the primordial follicle release because it is related to pressure gradients. And then think about the horse ovary. The horse really never goes into menopause, but its ovary is like a solid rock. And if you try to do stimulation to get eggs from a horse, you'll be happy to get 1 or 2 eggs. You really have to reach in there and get antral follicles and do IVM on them to do horse IVF. And so that's that. It's almost all ovarian cortex, and they have a very, 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 very slow recruitment rate of primordial follicles and a very low number of eggs, and yet they last until the horse dies. So what is it that locks and releases the primordial follicle? I'm making the point that it's stromal tissue pressure. Now, Hayashi has pointed out that it's intranuclear FOX3 that is the actual nuclear agent of this. And you saw today how he was able to manipulate FOX3 in order to turn a follicle into a primordial follicle and to lock it. Or indeed, he can get FOX3 out of the nucleus, and then he can activate and get the primordial follicle. But one thing interesting, what about the dead tissue in menopausal women? We've already, and believe it or not, I'm sticking to my time here, and there'll be time for questions if you want. As we've already seen, there is a reduction in the rate of primordial follicle recruitment as there is a reduced ovarian reserve. So that at some point in time, the ovarian reserve is so low that the reduction in recruitment results in trapped follicles that just aren't getting out. So if we look at a menopausal woman, not 10 years postmenopausal, but say in the last 3 years, there are usually a few eggs trapped in the cortex of that menopausal woman with POF. And you look carefully at them, and they're really good quality eggs. And so if you can just untrap those eggs in menopausal women, you can use them because they have not run out of eggs yet. So we now understand the mystery of resting oocyte recruitment and depletion. We have a unifying mechanism for adult resting follicle recruitment and for fetal oocyte arrest. Without a steady, controlled release of resting follicles in the adult, women would run out of eggs prematurely. If fetal oocyte arrest did not occur after meiotic activation, there would be no oocytes at birth. And as ovarian reserve goes down, the rate of primordial follicle depletion also goes down. But what if we were to bypass the primordial follicle? Well, I was with Katsuhiko 2 years ago, and actually I was with him when he took that fantastic picture of the 2 pups that came from skin cells. And this is the paper by Hikabi et al., and Ori was his chief technician on that paper, and I was really happy and excited to be with them when they actually did that work. But what was interesting and relates to our work with ovary transplantation and why it can be that it's so hard to culture these primordial follicles, and yet when we do a transplant, we have pregnancy rates of over 75%. They just seem to function normally. And that's because by making skin cells into IPS cells, into PGC-like, epiblast-like cells, into PGC-like cells, he's skipping that primordial follicle phase. And that's his diagram of it. And he did this, and I borrowed his slide, because you can see what we're missing out here is we're missing the primordial follicles. And so he is able to skip that phase and actually culture these eggs into mature eggs and have babies from them. So the origin of all germ cell lineages we know is specification in the epiblast, but they are not primordial germ cells yet. And I know because I've studied this now, what are the genes relating to it. You heard about it already. Simply genes like Dazzle license these primordial germ cells to go into meiosis and to lose their pluripotency, because otherwise they would be tumors or they wouldn't work. But this is just the summary from the original paper that Mitanori did with Hayashi, and Mitanori is focusing more on sperm and Hayashi on oocytes. But this was the classic study in which they showed that PGC-like cells, if they're surrounded by fetal somatic tissue of the testes, they make sperm, and fetal somatic tissue granulosa cells of the ovary, they make normal eggs. And now Hayashi's been able to complete the cycle, starting with skin cells and going to epiblast cells, and then going to skin cells again from the progeny of those original skin cells. So to me, though I'm not a scientist, I am very, very excited just to see that we not only have very high results, robust results clinically with preserving fertility for patients with ovary freezing, which is much easier than egg freezing and has all these other benefits. I mean, I'm excited about that, but also I'm excited that this allows us, through collaboration, to really learn more about how this mysterious organ, the ovary, works. So, Milton, I really want to thank you for inviting me. Fearing, I want to thank you. You deserve a thanks. I said nothing about Fearing products, and in fact, I even decried having to do ovarian stimulation, and I appreciate the open-mindedness of you in supporting my talk, and I'm happy to answer any questions, because I think we have plenty of time for that. Thank you.